Good. Good morning and happy last day of winter as spring is looking at us tomorrow and warmer weather is coming. It's a real treat for me to introduce my longtime friend and partner, Dr. Marian Michaels, who's going to be giving this really, I think, important talk. Marian is a professor of pediatrics here at the University of Pittsburgh School of Medicine. She grew up in Pittsburgh, moved to New England where she did her undergraduate, and then went to Philadelphia where she did medical school and then stayed on at CHOP. I'm interested to see on Marian's pre-prepared notes that she said she began her ID training in Great Ormond Street, which I knew about, and it's true, but I never knew she counted it for public announcement. Then she came to us, did her fellowship here, stayed on, and has been a lifer like me since fellowship, and remains one of the key players in our division of pediatric infectious diseases. Marian's career has worked really extensively with infections in children, both in the community and in the hospital. She's been interested in compromised hosts, but also in normal children who've had the congenital infections, what have you. Marian is exceptionally passionate about what she does and very passionate about topics that are going to be discussed today, particularly perhaps the role of vaccination and losing vaccination in the reemergence of these infections. So it's a real treat for me to introduce to you today my friend, Dr. Marian Michaels.
Well, thank you, Michael, for that wonderful introduction. And thank you for inviting me to come talk today about emerging and reemerging infections. My disclosures are here, and I threw in a disclaimer because as I went through this talk, I realized, boy, it really seems disjointed. But I think it's because there's a purpose to it, because there are so many infections that I really don't want people just concentrating on a virus or on a bacteria, but really get a whole gamish of the different mechanisms. And then a theme, if there should be a theme, is maintain your sense of curiosity and humility during the talk. And then I thought I should throw in one more disclaimer. I am not a basic scientist. If anyone asks me about real, true pathogenesis, I'm calling on with great humility my colleagues in the audience to help answer those questions. So, in 1967, the Surgeon General of the United States, William Stewart, stated, "The time has come to close the book on infectious diseases. We have basically wiped out infection in the United States." And even then, now I was pretty young, so I don't think I was paying attention, but it seems curious that someone would say that, but from everything I read, he truly believed it. And if we look at it from his standpoint, I could understand it. Smallpox wiped out from the United States since 1952. And at the time he made that proclamation, it was almost gone from the entire world. Polio, gone from the United States. Measles, virtually gone from the United States in 1967 when he said that. But as Jeff Goldblum, a Pittsburgher, playing Dr. Ian Malcolm, said in Jurassic Park, life finds a way. And sure enough, the Surgeon General's prediction was clearly premature and wrong, as we all saw so vividly when the epidemic of AIDS and HIV hit in 1981, when arthropods like the mosquito for West Nile came into the United States in 1999 just to New Jersey. They quickly spread to New York, began to spread quickly after that westward. And as you can see, by 2024, virtually has been seen across the entire country. Lots of different infections have emerged. Zika virus, I threw in chikungunya in case Dr. Dermody is paying attention. And with that, I wanted to just give you my objectives. I really want to give an overview of how and why infections emerge or reemerge. I am going to talk a little bit about the pandemic, but mostly the influence on changing patterns, and then make some predictions for the future, as well as end on mitigation strategies because I don't want us just left with doom and gloom. So is anything really new? Oftentimes, it actually is a previously known microbe that has increased severity, that perhaps there's actually ascertainment bias. The more we look, the more we find, or something that we couldn't find before but has always been there. There can be changing epidemiology from climate change, from animal or vector migration, as we saw with West Nile, and then, of course, from the complexities of human behavior. And finally, sometimes there really is something brand new that hits us like the pandemic. So before I go to some of those examples, I want to tell a story. It was a Saturday. I was, of course, Sans fellow and I was hoping to get out early. And I get a call from the emergency department that a child is coming in from an outside ED with a rash that started on the face. He already had a high fever and he presumptively had pneumonia. And oh, by the way, the family does not believe in immunizations. Now, I don't think it's a surprise that someone in this audience is thinking that this could be, maybe everyone should just say it, measles. And this was in March, but it was in March of 2009. And of course, it did turn out to be measles. The mother was angry. She was defensive. Her arms are folded tight against that child. Her lips were pursed as we tried to ask her questions and ascertain who else was sick in the family and where had she been. Well, it turned out that along with our 23-month-old index case, the brother had the same symptoms, just a little bit less severe. And the father also had mild symptoms. And here comes in being humble, because I looked at the father, I listened to him, I knew he had had at least one immunization as a child. And I was like, I'll test you, but I don't think you have measles. So maintain a sense of humility, because of course he did have atypical measles. When we asked where they had been, she very curtly and defensively said, "Your hospital." And sure enough, 5 days before, the brother, who had a draining ear and had a high fever, had been in the ENT clinic and then broke out in a rash later that day. But clearly 5 days is too short a period, and that was not the source for where the measles came from. But if we go back 2 to 3 weeks before, on March 10th, 2009, the family had in fact been in our emergency department for 10 hours. It was the patient, the brother, the mother, and the father. And accordingly, that is the right time frame. And we too believe that our hospital was probably the source. Now, from a infection prevention standpoint, it is really important to go backwards and go forward. So where was the source, which we're thinking our place, and who else could have been exposed, and go forward for who could these children have exposed and what do we need to do. So they're infectious 4 days before the rash, 4 days after. That's good. We have that figured out. Luckily, neither boy was in school. There was no travel, no reverse travel. And because the brother had been sick with ear infections, they mostly had been at home, aside from children's and the primary care office. So the ENT waiting room, while not the source, was a big potential place for exposures. Everyone in that waiting room and the staff, the primary care office, the outside ER, even the ambulance workers who were not masked. So measles in the Berg in 2009, as we went forward, we recognized that one of our wonderful emergency department healthcare workers who had worked on that day, March 10th, developed a rash 13 days later on March 23rd, and was known to not have converted despite having received MMR ×2. Of course, being a good doctor in our hospital, she worked multiple shifts while sick, and she gave a lecture for the EMS conference at Seven Springs despite being really pretty sick. On 4/1, we had an 11-month-old coming to the infectious disease clinic with fever, conjunctivitis, and a rash to rule out Kawasaki disease. And luckily, we already knew about the potential measles exposure and found that he had been in the emergency room on March 10th and accordingly got him into isolation right away. And he was not immunized, not because the parents were against immunizations, but because of his age. And then on 4/3, the CDC came back that the index case had a virus of measles suggestive of India or United Kingdom. And meanwhile, we were looking hard as well with our Cerner system. We had our family of 3, we had our ED doc, we had an 11-month-old, and where they all intersected in the emergency room, we had a youngster who had traveled from India to JFK with a high fever, got in a car, and on their way to Pittsburgh to visit families, developed a rash and came to the emergency room. And accordingly, we had our source. Well, this was incredibly educational. First, it was an intense amount of manpower that went into doing the infection control for this family. 1,856 people had to be contacted from potential exposures at Children's. 181 healthcare workers potentially exposed. 9 were IgG negative and had to quarantine for 18 days post-exposure. And that actually changed our mechanism of what and our policies of what we do. So someone working today, we know their serology up front so that we don't have to rush and do it in this kind of situation. So many groups were involved: the Allegheny County Health Department, the Pennsylvania Department of Health, the CDC, the New York Quarantine Station. And in conclusion, from this source, we had 5 secondary cases from children's exposure. So many lessons. First of all, be curious, not judgmental, as Walt Whitman tells us. A child coming from India with a fever and a rash should have prompted a little wider differential than some sort of virus. And then second, from my standpoint, we had to care for this child and family. This mother, as I mentioned, she seemed really angry, but in fact, it wasn't anger. She was petrified. She didn't care about the infection control component that we care about. She needed to be reassured that her child, because of this decision that she had made, was not going to die. And we needed to help her and to be non-judgmental and talk to her about immunizations so that in the future she would be able to do something. So once we said, we are going to care for your child, and did it in a non-judgmental way, the entire demeanor changed, and I think we were able to help her. And be humble. Boy, I did not recognize that the dad had the infection. I was willing to test him, but it did teach me about looking for atypical presentations in someone who might have had one immunization many years before. And then be prepared. The outbreak was limited because Allegheny County had superb immunization rates. And I think that is critical, and we will come back to that at the end. And then expect the unexpected, because as we were having our calls, Mike Green was leading the calls at Children's Hospital as the head of our infection prevention at that time. And as we were leading them, the CDC all of a sudden said, guys, we can't be on these calls anymore. And they were called away to take care of a new pandemic that was arising from Mexico at the end of March, namely influenza H1N1 2009. So with those things in mind, I want to go forward with some other ideas of how things emerge. So a previously known microbe can have increased severity. And I think a wonderful example of this, or perhaps a fearful example of this for those of us who lived through this time and know that it can come back, was in 1990, invasive group A strep shocked the world when the beloved creator of the Muppets, Jim Henson, died from invasive strep 20 hours after he was admitted to the hospital. It was that virulent. And many children that we were seeing were coming in with necrotizing fasciitis or severe disease after having had chickenpox, beginning to get better, and then having necrotizing fasciitis from group A strep afterwards. And it really was from a predominant M type that had acquired a new pyrogenic exotoxin. And a wonderful review by Barnett showed that there was several acquisitions of prophages, some that interfered with neutrophil effects, some that actually led to the exotoxin and increased virulence, that allowed this increase in invasive group A strep, coupled with the fact that there was a lack of host immunity, and therefore the waves of invasive group came through. Another example of a bacteria that we all know very well that acquired a toxigenic property was an outbreak that happened with staph toxic shock syndrome. And I brought this one up because it brings in human behavior and how that can impact things. So Procter & Gamble had just come up with a new highly absorbent synthetic tampon. They even advertised it absorbs the worry. And in a big marketing campaign, they sent 45 million free samples. They mailed them across the United States to women throughout the country. And so everyone got them at one time. Who doesn't love a free sample? My God, this was incredible. So it wasn't that the tampon per se was contaminated with staph. What happened was that women who were colonized with Staph aureus with the potential for that toxin now had a synthetic fiber on this tampon that was being left in for many more hours than usually would have been the case. It changed the vaginal environment, and it promoted the toxin to be produced. And accordingly, because everyone had it at the same time, many women were presenting with staph toxic shock and multi-organ failure all at one time. As you can see in the graph, I think it shows here. Where's my... Oh, well, I don't know how to get the printer, but I think it shows up there. And it really was associated with this Rely tampon, even though it itself was not the contaminated part. The sheer volume of women presenting actually led us a little bit astray to think that it had to be tampon associated, so that we missed it early and didn't recognize that that young children could also acquire this toxic shock. And if we had gone back and read our journals, we would have seen that James Todd, a very famous pediatric infectious disease physician at Colorado, had already described it in young children. And then certainly later we recognize the super antigenic exotoxins of TSS-T1. So I think the next idea to think about is the ascertainment bias, or improved ability to detect organisms. And the example I wanted to use here was human metapneumovirus. This was not a new infection, but it was newly discovered and first reported in Nature in 2001 by a virologist in the Netherlands. The virus did not replicate well in the continuous cell lines that we typically used in every virology lab across the world. And accordingly, it was not recognized until people had different techniques, newer assays, sequencing technology, and in some really lovely serologic studies, they were able to show that this had been circulating in the human population at least for the last 50 years. Now, armed with these new methodologies, our dear friend and former division head, John Williams, at that point, a junior faculty member at Vanderbilt, was able to take that, go back to stored samples of children who had been followed since 1979 or 1976, actually, who had lower respiratory tract disease but were negative for influenza, negative for RSV, negative for parainfluenza, the viruses we knew how to evaluate. And accordingly, it changed the whole tenure and pivoted his career to be looking at the next question with human metapneumovirus. So be curious. Take advantage of new things that come up, because they will impact your career. So let's go back to our previously known microbe and a couple other mechanisms that can happen. It can be changing epidemiology. This can be climate change, We all know too much about deforestation happening around the world, changes in agriculture, changes in industrial practices, changes in how the animal or vector migration is happening, as I showed in the first slide with West Nile virus, and then the complexities of humans, which I don't know how to predict what humans are going to do. But there was a wonderful article by An and colleagues, and she was very interested in this concept of climate change and how it impacted respiratory viruses. And she coined the term extreme precipitation events, or EPE, looking at heavy rainfall, drought, winter storms. It made me think about the winter storms we had this past year, cyclones, which luckily we don't have, and fires, and the potential for both direct and indirect effects. And while she was interested in respiratory viruses, I think it was very apropos to be able to look at others too, at fungal infections, at vector-borne infections, and then as well at viral infections. So let's just talk for a moment about how some of these things have happened. In the last 5 years, a lot of media and articles have been looking at the impact of climate change on fungi, particularly coccidioidomycosis, and the rise of seeing that disease in California, which is valley fever, and which we call cocci for short, because who wants to say coccidioidomycosis multiple times? The fires that happened in California, in Colorado, in Utah, as shown in this, led to a 60% increase in diagnosis of cocci in Utah, as well as aspergillus. And I think that it's nice to just take a moment to think through how that happens, because fires can really happen anywhere across the country. And Phillips and his colleagues talked about the fact that when you have a healthy forest, you have a wonderful, diverse community within that soil and maintains the fungi in there. With the fires that happen, you have an increase in dispersal of the particles, the fungal infections going into the air with the fire updrafts. And then post-fire, you now have a scorched earth that has been depleted of all the competitors and allows for the wind erosion to occur and accordingly fungal infections to disperse. Now, I say that because I brought this up and I thought about it because it's the West Coast. I was going to say who cares, but of course we all care. But fires can really happen everywhere. But when I was thinking about it, it's like, are there some examples of things which are near and dear to us right now? And I was like, I do know of one. And I circled this young guy. I guess this is a mature form. I'd have to ask Andy to be sure. But Ixodes scapularis, the tick that has Lyme. And I thought that was a great example of how things migrate and change. Now, when I first came to Pittsburgh as a junior fellow, my seniors, including Mike, took me to the Infectious Disease Society meetings. It was amazing. It was the best way for a fellow to ever be introduced to infectious diseases. And I remember there was a talk by a rheumatologist, Dr. Steer, talking about this new disease, Lyme. It was incredible. And luckily, it wasn't in Pittsburgh. And so, we saw a few cases, and you can see on the CDC map in 1995 of where Lyme was being diagnosed. Yeah, there were a few cases, but most of those patients had all traveled. And not so surprising when you look at a map of where Ixodes scapularis was established, which are the red dots, you can see that we in Allegheny County were mostly spared from that organism. But Lyme comes to Pittsburgh. I got called on a consult. I know this is probably not HIPAA safe, but I had the date still on the picture, so I knew exactly when this happened. But I got called to see this young boy with a seventh nerve facial palsy. Now, neurology had already seen him. They saw him in the emergency room. They already had him on acyclovir for herpes simplex. They had him on steroids for potential idiopathic facial palsy. And they had him on ceftriaxone in case it was Lyme disease. And he had a mild pleocytosis as well. But then I pulled back the covers. And I hope that shows up, but he has beautiful disseminated EM rash. And I could say, we can get rid of that acyclovir. We can get rid of those steroids. And in those days, we did actually still use ceftriaxone for the pleocytosis. But as I was talking to this mother about how curious it was that he had never traveled outside of Pittsburgh, I got a page from the emergency room that they had a young girl down in the emergency room with suspected Lyme meningitis. And then 2 hours later, I got another page of a boy with an EM rash and a facial palsy. And I know it takes a little bit to hit me over the head, but these 3 cases all in one day, and they all had never traveled outside of Allegheny County. I was like, looks like Pittsburgh now has Lyme disease. And sure enough, when you look at the CDC map that came out later for that same year in 2010, you can see that there was a lot of more diagnosis of Lyme. And when you looked in 2015 for where Ixodes scapularis was established, all of Pennsylvania had it. And in the most recent maps that I could find on the CDC, you can see that I can't even find Pittsburgh because of the blue that has taken over. And also the Ixodes scapularis has moved forward as well. So I think that was a wonderful example of how migration can emerge diseases in an area where they had not been. So I want to turn now to respiratory viruses. Oh my God, there are so many respiratory viruses, as this Scottish virologist Ian had tweeted. I don't know how to tweet, so it's just as well. And kids, as we know, they love to share their snot with everyone, so not a surprise. Now, a number of my colleagues, John Williams, certainly Megan Freeman, who's in the audience, Bob Hickey, Judy Martin, we've all been fortunate to really be part of the CDC National Surveillance Network, which is called New Vaccine Surveillance Network for acute respiratory as well as acute gastroenteritis, mostly in the hospital and in the emergency room, but also in the outpatient to look at viruses that are happening today. And this week, when we pulled up the data just from Pittsburgh, looking at October 2024 through January 2026, I thought it was helpful to just show, you don't have to know which virus it is, but lots of different colors representing a different virus, going up, going down, but going across the entire time. So lots of viruses circulating all the time in Pittsburgh and certainly across our country. So with that in mind, I wanted to sort of think about what kind of changes happen with the climate change. And so come back to On's premise of the extreme precipitation events and what could happen, and some of the direct effects as well as indirect effects. So from the direct effect, she talked about how cloud cover, I was like, oh my God, there's always cloud cover in Pittsburgh. I'm surprised we don't have more viruses from this. But because of cloud cover, you actually are decreasing UV irradiation and decreasing the deactivation of viruses that can happen. And also, because of the droplet size that can be there, there's actually an impact on how long they stay in the air and can accordingly go person to person. Then, with extreme storms, everyone is moving indoors. I mean, my God, I don't think I wanted to go outside if I wasn't on call during those snowstorms we had. I think Mike and Terry had to be the ones to brave that storm. But everyone went inside. And with the use of being inside, you're going to increase the use of ventilatory systems, decrease humidity, and this is going to lead to increased circulation of the viruses within the house. And then if you have periods where people are actually having to sequester together, which luckily we haven't had happen to us, but you can think across the world with war-torn happenings that people often are seeking shelter together, that this crowding in particular in these shelters is going to have attendant mixing and also person-to-person spread of viruses. So I just think that those were interesting theories to consider. Now, does that actually happen? It's a good theory, and I think it's probably real, and we have to take it into consideration. But a virologist in London actually said, that's probably not what happened. And he noted that with climate change, he actually saw a decrease in RSV viral spread and noted that the RSV season shortened in England as England was becoming hotter. That would be wonderful if that happens. That was 2006. I don't know if that's true. And there has been so much that has happened. So I want you to remember RSV because I'm coming back to it. But let's change the tune for a moment and go to the last premise of how things come in. And this is truly when we have a new microbe enter into the world. And this is usually from mutations and genetic changes. And just looking at this century, we've already had 4 pandemics: SARS in 2002, the pandemic H1N1 in 2009 that I mentioned that took away our CDC from our measles evaluation, MERS in 2012, and then SARS-CoV-2 hitting us in 2020. With SARS, this was a humbling experience. It was a novel coronavirus. It emerged in November of 2002 in Guangdong province, China, and then spread with a vengeance through the world and often through hospitals. And I bring that up really to remind us that we have to be careful. It likely came from live animal markets, whether it was the bat, whether it was a civet, not really clear. But luckily, this epidemic ended in the summer of 2003, but it left in its road a really horrendous amount of deaths. There were 8,096 cases in 29 countries. There were 774 deaths, and nosocomial spread was frequent. And 21% of those cases were healthcare workers. And I think Mike and I certainly remember that colleagues in Toronto really died from this disease. So it was really a humbling experience. Well, how did these things happen? So many viruses cross species all the time. They travel from one to another, and it's amazing that it probably isn't causing disease more frequently. And as Holmes mentioned in one of his reviews, the inconvenient truth is that viruses are ubiquitous components of an increasingly threatened global ecosystem, and they regularly move between interacting species. Now, most often, they are not associated with disease, but sometimes they are. And I think the best example of that is really with influenza. So influenza, an orthomyxovirus, it's an RNA virus, it's single-stranded, and its polymerase, when it replicates, it is prone to making mistakes. It makes mistakes on purpose. And these small mistakes, when it makes small mistakes to the hemagglutinin antigen, surface antigen, or to the NA antigen, that when it makes those small mistakes, which happen frequently, we have drift. And this is the reason that we need a new vaccine every single year. Also, our immunity doesn't stay that well, but we need to have those new vaccines, which we try to make an educated guess on which one is going to be circulating in our vaccine efficacy, which sometimes is better, sometimes is worse. I know this year wasn't as brilliant as it has been, but it still had some efficacy. It's better than no vaccine, but it basically varies on whether we were able to have that educated guess talk about what those drifts were going to be. So drifts, small changes, common. But when we have major changes, when there's a huge reassortment, usually from a mixing the avian, of the birds, the bird flus with swine, and having a human virus in there as well. And you have these big changes. That's when we have a shift, and that is when we have our pandemics. And when it comes back into the human population, we have no immunity, and so ensues. I think 1918 flu pandemic was probably the best example or worst example of what can happen in the extreme mortality. And I know that even today, there's still debate on why there was so much extreme mortality with that second wave. I think it wouldn't have happened if we didn't have World War I happening at the same time. But we do know that it led to 50 million deaths. And a lot was due to the changing of the environment, to have the intermingling of people from different areas that also helped with the rapid spread. There were crowded barracks. These barracks were with people from all over the world together. They were near waterways with suspected mixing and reassortment of avian flu viruses with the pigs, the ducks, the poultry that were being kept nearby for food for the soldiers. And when people looked at the viral sequences years later from the exhumed bodies, they suggested that this was indeed of avian origin. With that humbling experience, I think we can all remember back to other viruses that can change, not just the influenza or the mix of viruses, but likewise coronaviruses are ones that are easy to get into our population. It's hard for me to believe that it was just December when that article came out in 2019 about a cluster, a small cluster. I think there were just 3 patients that were recognized in Wuhan as having had a similar exposure at the seafood live animal market and were being hospitalized with a severe pneumonia. A month later, it was sequenced and we knew it to be this novel coronavirus, but I don't think any of us were prepared for how fast it would spread across the world. Now, I am not going to talk about pandemic coronavirus 2019 in any great detail, but I do want us to remember it and how it impacted other viruses. So let's come back to RSV. This is the NVSN data from 2017 to 2020. And as we all know, RSV circulates every year, comes up in the fall, goes back down. Everyone by age 2 has been infected with this virus. But then the world shut down with COVID-19 in March of 2020, not just the United States, but everyone. We taught everyone how to do proper cough and sneeze technique. We masked everybody. Starzl was masked. Dippy was masked in front of the museum. I don't know how they got that mask on him, but I loved it. And the schools shut down for better or for worse, and we learned how to do telehealth. And with that shutting down the world, something bizarre happened with RSV. It disappeared. Not just RSV, but all of the enveloped RNA viruses, flu, gone. HMPV, gone. Parainfluenza, gone. It was crazy. It was amazing. And then when we opened up the world, we had a change come again. So let me just orient you. I'm going to try and get this. Oh, here. Can you see? I don't know. Can you see the, yes, yay, hooray. Okay, so all these different colors represent RSV during a different year. And again, sometimes higher, sometimes lower, but they're all coming pretty much the same time in the fall, just like we've always expected. And then it went away. So we didn't have it happen in that 2020, 2021 year. But when we opened up, it came back, and it came back at a bizarre time in the summer. Many of you in this room will remember how crazy it was that it did that. It wasn't just in the United States. Japan, crazy time. Denmark, crazy time. And then when we followed what happened in the years subsequently, again, this is the NVSN data. I have the red one is when RSV came back in the summer. And you can see that in 2022, it seems to be moving back to the normal period in time. Now, whoops, it did have some changes, and shown by Rao and her colleagues in Colorado, it was an older population. And not only were they older getting sick, they were in the ICU, an older population. So there were some changes with that. Long-held beliefs had to be re-examined. Only infants were at risk for disease because of their airway size and immunity. We were wrong. Be humble. Older infants and children not at risk for severe disease, they were in our ICU getting intubated. We were wrong. And temperate climates only have RSV circulated in the fall and winter. We were wrong. So it's tough to make predictions, especially about the future, as Yogi Berra says. And this one, I'm not 100% sure what's going to happen. But let me just remind us. Now I'm putting up the flu data, the RSV data, pre-pandemic, coming in the fall. Flu always would come right after. RSV would come, it'd begin to go down, flu would come up. That 2024, 2025, it looks pretty normal. RSV came up in the fall, flu came right after. But on Monday and Tuesday, when I looked at the recent data from NVSN, we had flu. Where the heck was RSV? And now it is beginning to come back up. And I couldn't put in this week's data because I only had from Pittsburgh, but we are seeing a little bit of a surge. So I'm so interested to see what's going to happen in the next few months. Is it that RSV overshot? It was like, yep, I'm getting back to normal in the fall, and now I'm going to come late in the beginning of spring? Or is it that we have had human impact because of our maternal immunizations, because of our nirsevimab, and now we're 5 months later and we're seeing this surge, and we're going to have to re-evaluate, when do we immunize our mothers, our pregnant women? When do we immunize our children? Maybe we're going to have it go year long. All right, so back to making predictions. Like Puxatawny Phil, I'm going to try. I sort of want to end well, I'll end on a happy note, I promise. But we are in difficult times. There's no question about it. This is a rough time for all of us, for all kinds of reasons, but particularly from the infectious disease side. With the measles immunization, my God, by the year 2000, the United States was measles free. We had no endemic measles. And look where we are now. In 2025, 2,284 cases and 3 deaths. 3 deaths, you could say, well, it's only 3 children. 2 children and 1 adult who did not have to die. We take care of children all the time in this hospital, and oftentimes we help them move into that position of where they die and where we are not able to help them survive. But when we have someone die from something that we know we could prevent, that is a tragedy. It's a travesty. This is something that we should not be having happen. And why has it happened? Well, I think this picture shows the story. We need 95% or better vaccine coverage for herd immunity for measles. And that powder blue, I don't know what color it is, blue, green, whatever you think it is. But you can see there are very few states that have it, and Pennsylvania isn't one of them. And even in Allegheny County, we are below that 95% vaccine rate. And so it is on us to really change this around and keep talking to our family with a curious mind and humility, not reprimanding, because that doesn't work. So the things I'm afraid of, I am afraid that we are going to see an increase in other vaccine preventable diseases, meninge, pneumococcus, even, my God, tetanus. These are diseases we shouldn't have to see. And I'm worried that if we don't change this around soon, we are going to see those too. And also, I worry about H5N1 avian influenza becoming more pandemic, more pathogenic, because it is here. It's in our dairy cattle. In 2024, 20% to 30% of tested milk is positive for this virus. And the good news is pasteurization kills this. The bad news is we have some people in leadership who are touting raw milk, and we just can't permit this to go on. So I am going to end on a good note. Life does find a way. And good life can find a way. And we do have mitigation strategies. We need to continue to do the surveillance so that we can rapidly look back and see what worked, what didn't work, and where do we go. And that has to be locally, nationally, and worldwide. And then hand hygiene and cough and sneeze etiquette. I mean, we know we can teach children. We saw during the pandemic that it worked. We need to continue to do that. And my God, no one in the healthcare world should be touching their patients without washing their hands. And then we do have to help our families with immunizing. It does work. It's what got us out of the problems before. It will help us again. And then at times, remember to cocoon those vulnerable patients. And the last slide that I want to end on is that I went to the CDC, which I do have to say, so many of my friends still work at the CDC. There are good people there, even though I know the leadership is lacking at the moment. But when I went on to just see what they had on measles, they had the best way to protect against measles is vaccination. It was there. It's still there. I don't know why I should be so surprised that the CDC would have that there. Would I like it to have been bigger? Would I like it to have not gone away? Of course, but it gives me hope. And then I would still say, hope, but still please use the societies for your vaccine recommendations at the moment. And then with that, let me end, and I'm happy to entertain questions. Thank you.